Welcome to One on One. I'm your host, Lee Adams, and today we're going to talk. Our guest is a medical professional, and we're going to talk about updates and what's going on within the power of organ donation. And organ donation has saved hundreds of thousands of lives over the years. Our guest today received her medical degree in India and did her residency here at the University of Pittsburgh Medical Center here in Pittsburgh. She's currently the medical director of the UPMC Liver Donor Program. Please let me introduce Dr. Swetha Ganesh. Hi, Dr. Ganesh.
Hi, thank you so much for having me. It's a pleasure to be here.
You're welcome, you're welcome. I'm glad you're here.
Thank you.
So let's just talk a little bit about, just real quick about India.
Sure.
What was it like growing up in India?
So Indian culture is slightly different in the sense that, as you know, it's the densely populated nation in the world next to China. And I grew up in a large family. We had 36 people.
36?
In our 36, my grandparents and my parents and, you know, their siblings, all of them.
It's a big family, Dr. Ganesh.
It is a big family. So, you know, sometimes I wouldn't even know the difference between who my cousin is or my own sibling. I have my own sister because we were all a very, very close-knit family. So in my mind growing up, there was no doubt you took care of each other. It is, you know, if one of the family members is sick, you just take care of each other. There is, you know, there may be conflicts, there may be problems, there may be issues, but at the end of the day, we all had a meal, supper together in this dining table, and then we went to bed, we resolved all the issues. That's how we lived because our grandfather wanted that. So we hugged at the end of the day, and whatever problems we had, we resolved. So for us, it was a more intimate family connection, and that kind of that I do feel bad for my son, who does not have that here. Meaning in the sense that yes, we do have lots of friends who are like families for us here, and my patients are like my family, but the whole concept of growing in a joint family and having that background, which he does not have, I do feel that he has missed out on that.
I see. So what's a fond memory you can think of growing up in India?
Several of them. Playing with my cousins, my vacations, riding on elephant, and a camel, or we would go to forest for camping. What can I even say? Like there are several to share, but we all did that as a family. We would go in, all of us, 36 of us will go together as a family. We did things together as a family.
How about that?
And some of the palaces we visited, like Mysore Maharaja Palace, and we rode on an elephant. That was the first time I rode on an elephant, and that was a phenomenal experience. And we did go to Kashi, Varanasi, which is one of the pilgrimage place, and we all went as a family there, and those are really great moments. And sometimes, you know, when we do have the fond memories I do have is that whenever I do have a conflict at my school or a friend or with one of my cousins, I could go to an uncle, or, you know, we all have a favorite uncle or my grandfather, and I would go to them and ask, how do you think I should deal with this? And they were so wise, and they always told me, take the high road, pick your battles wisely, and karma will take care of it.
And great advice, Dr. Ganesh.
And they say, when people go low, you go high. And you know, and sometimes I say, I'm so angry and immature at that time, and I would react, and my grandfather would say, don't be impulsive, don't react, just sit tight on it, and you know, you don't have to lower your standard or class. For if other people have a different standards than yours, don't lower yours for them. Keep your standard and your code of conduct. and your moral and ethical values. So, what I can say is that the way I was brought up and some of the values I have right now, which defines me, is because of the family background. My core value, my conduct, my ethical standards, and my moral compass and my conscience is because of my family and the way how I was raised.
Well, you had some terrific elder relatives there that gave you some great advice.
Absolutely. And my grandfather always said, truth is God, and believe in righteousness in conviction and fight for what is right.
Boy, you had some good mentors there, I'll tell you.
Yes.
You know, I never rode an elephant, but what made you want to go into the medical field?
It may sound like a cliche, but this is the exact story. My dad is like God to me. So when I think I was a second or third standard student, and I was playing, and my dad brought me and sat on his lap, and he said, I love all of the kids the same way, but all my brothers, my uncles, had boys. My father had 2 girls, me and my sister. And he said, my dad wanted me to be a physician. I could not meet that standard. And being a physician makes a significant difference in people's life. You can touch people's life in any way. But however, being a physician can touch people's life in a big and significant way. And I feel like I failed my dad. And people think in India it was slightly different those days, that women were mostly expected to be married and be a homemaker. And my dad said, I would be very proud if you made a significant difference in the world and prove to the family that you can break glass ceilings and show to the world that you could make a significant difference to the people and touch people's life in some way. And that maybe I failed my dad, and then maybe you could not fail me, he said. And I didn't understand what it was, but I don't know whether that was the instigator or what it was. From that point onwards, I became inclined towards medicine. And even the toys he would buy me would be related to a stethoscope, like a toy stethoscope. Whether all my other female friends would be playing with like little dolls, I'll be using a stethoscope. And then my passion for medicine continued to grow, and that's
Interesting.
and that's how. And I don't, it's not because I became a doctor because of my dad, but that thought in my head of making a difference in people's life.
They planted that seed.
Planted that seed.
Yes.
And he would read stories to me about Florence Nightingale and Madame Curie. And the other thing he also said was, which stuck to my mind, is, when your kid's growing up, people would say, oh, your child is so pretty or so good. And my dad would pull me aside, them and me, and say, no, that should not be your definition. Being pretty, being nice looking should not define you. You are much, much, much more than that. You're intelligent, smart, you're independent, you're making a difference in people's life. Should define you, and your character and your conduct and your moral values should define you. So if someone said you're pretty, you're beautiful, I just don't ignore that comment, he said. No, I'm not saying, people usually, to be polite, they say that.
I got it.
I'm not saying that, like, to any female in our family, if any comment came that way, my father always stopped them and said, they are intelligent, they are smart, they are well read, that's how he changed it.
Well, you sure had some terrific elders to learn from. Now, India is a long way from Pittsburgh. What brought you to Pittsburgh?
So that's a great story. In India, we have arranged marriages. And when I was in med school in India is usually 4.5 years and 1 year of house surgency. So usually in India, in the place where I come from, we get married very early, 18, 19, 17. So my father really worked very hard to find a perfect match for me. And at that time, my current husband was studying at USF. He's an Indian too. And so we met, and then there is the whole process of how we meet. And then a few days later, we got married. Not few days, he came there and I met him. And then I liked him, and I told my dad, I think this is the guy. If I didn't like him, I could say no, but you just have one chance for 10 minutes. And then I talked to him, and I ended up coming to US because I married my husband.
Interesting. So different than the United States. But that's a very interesting story.
Because we don't date
right.
or
I get it. I get it.
those days.
Yes. So now we could talk about this for hours.
Yes.
Which I know you could and I could, but I want to talk about
Absolutely.
the work that you do.
The
now,
passion.
You are running the liver living donor program at UPMC. Is that correct?
Yes, I'm the medical director of the living donor program.
Okay.
Yes, liver.
Right. So what's the difference between a cadaveric liver and a living donor liver?
So just to give you a prospect, I'm sure you know this because you have had a you have had a transplant before. There are 14 to 15,000 patients waiting on the liver transplant list. What that means is that how that affects our patients is that there is 15 to 25% of the patients on the wait list may not have an opportunity to get a liver, or they succumb to their disease, or they lose the window of opportunity. The reason being, the patients are listed on the wait list based on a score called a MELD score. Sometimes MELD is a score based just on a number. It's based on the jaundice number or how thin your blood is, and based on your kidney numbers. But it does not look at a patient as a whole, and that's the UNOS allocation system. That's the best system they have. But even though MELD is a very good system in assessing the wait list mortality, it does not accurately represent the prognosis for all the patients. For 40% of the patients, it does not accurately represent that. So what do I mean by that? Some person in the wait list may have a MELD of 17. He may be O blood type, but he may be losing weight. He may have temporal wasting. He may be deconditioned, have fluid in their belly, have poor quality of life, and have had a lot of bleeding. And we know that he's not going to get a liver for a long time with a MELD of 17. And if he doesn't have 5 years to live. And as physicians, we have the responsibility to try to get him the best survival advantage and the benefit to access him for living donor liver transplant. And so the living donor liver transplant, in my mind, in our mind at UPMC, is the first option and the safest option. Because as you know, the transplant should be given at the right window, as the time is of the essence. If it's given before or after, it's not going to work as good. It should be given at the time when you know that the patient is at their best health. And when you know that the patient is at their best health, they do well, the outcomes are better, and they walk home. You walk into the OR, you walk home. But when the patient is yellow with a MELD of 45, they are in the ICU, they get a transplant, and we know that their rehab, their post-operative, their complications, all of that is much higher. So that's why living donor liver transplantation should be embraced more, and especially that we know living donor liver transplantation, the liver grows. So as to your question, cadaveric liver transplant means that it is from someone who's deceased and it's a full liver. And living donor liver transplantation is part of the portion of the liver is taken from a living member, and that's given to the recipient. And the recipient's liver is taken out completely, and this portion of the liver is given to the recipient. In both the recipient and the donor, the liver grows back to full size in approximately 10 to 12 weeks. And when people know about the liver growing back and regenerates, liver is the only organ which has a unique capacity to regenerate. More and more people are coming forward to be a donor and wanting to be a donor.
Now, kidneys, there have been a lot of liver or living kidney donations, but we have 2 kidneys, and that means we give one up and then we have one left. But with the liver, I think what you're just alluding to is that people just do not understand that if you cut part of the donor liver, it will regenerate within, what, 3 months, I think is what you're saying.
Absolutely.
Yeah.
You nailed it. And sometimes I do say that, the risk of complication has been also implicated in kidney, but for kidney, it has become like a norm. They say, oh yeah, I'll donate a kidney. But sometimes the risk of complication and that having only one kidney, everyone should donate kidney or liver. I'm not discouraging anything at all. But in my mind, people are more open to donating a kidney as opposed to liver. But in my mind, liver regenerates, but kidney does not grow back. So people should be open to be donating to liver also. And I think because of people like you and because of people like media, we are able to take the message to the public that the liver can regenerate.
Yeah, I think the public is used to hearing about kidney living donors, but the liver part of it is relatively newer, and this is one of the reasons we're doing this show, so people can understand that yes, you'll get part of your liver taken to save somebody's life, but it's going to grow back. Right?
Absolutely. The liver does grow back.
Yeah. So does the living donor have to be a relative?
Doesn't have to be a relative at all, and that's a great point you're bringing up. It used to be that before, biological donors were the only ones who were the living related liver donors. Now we have a program called a champion program, and where we ask the recipient to identify a champion in their support system, and that champion serves as an advocate in finding a donor for the recipient. And through multiple avenues, through either Facebook, church group, or through their bulletin board at work or alumni association. So last year alone, at least 30% of the people whom we transplanted and the living donor liver transplant, 30% of them were non-biological donors. These people were not known to the recipients at all. They came in and said, Doctor, I want to give a liver to this person, and I do not know this person personally at all, but I know my cousin's friend's wife knows this person, and I want to donate. And we have to really thank the Facebook and people's altruism for all of that to happen. They do not have to be related at all.
And what a gift that is. They're giving the gift of life.
Amazing.
It is amazing.
It is amazing.
It's really amazing, and I know all about it. So what are the requirements to be a living donor?
Sure. Usually we expect them to be reasonably healthy between the ages of 18 to 55, and the BMI around less than 33 or so. If they're a little higher BMI, we make sure that we send them to our weight loss clinic run by Dr. Bihari and get them to the appropriate weight. And they should not be actively abusing any drugs and not have hepatitis B or C actively, or any HIV, or any major diseases like type 1 diabetes dependent on insulin, or any active cancer. So generally in good health, or have coronary artery disease with a CABG, things like that. Generally healthy, but if they have high cholesterol on medication and diabetes on one medication, those are okay. We can work through that, but we want them to be overall generally healthy and not be smoking. If they were smoking, we ask them to quit, and not drinking excessive alcohol, and we ask them to quit. So, and we do a battery of tests to ensure that they're very healthy, and also do a lot of imaging to ensure that they have the capacity to regenerate the liver.
So somebody that's watching this saying, maybe I can be a living donor, can they go to their own doctor to get evaluated, or is it better for them to come to you?
I think it's better for them to register on our website, livingdonor.org, and they can. It's a PDS form, which is a patient data sheet form, and then we screen them out. Sometimes it screens them out on automatically, but sometimes we review them, and if they seem like a good candidate, we bring them for a teaching if they're altruistic donor, and they can. If they're out of state, we do a video conference teaching, and if they're in state, we schedule them for a teaching here. And if they pass those and they still want to come for a formal evaluation, then we bring them for an evaluation. So I think it would be better if they just went through our system. It would be easier that way.
I see. So what you're saying is a living donor has to be approved by you in order to become that.
Yes.
But recipients also, they have to be approved also, correct?
Absolutely.
Yeah.
The recipient would undergo a series of testing and a battery of testing and imaging and all of that for 3 days in Star Cell Transplant Institute by a complete team. It's a pre-liver transplant team, and the living donor liver transplant has a separate team, and that team takes care of the donor, and usually their testing is a day and a half. Actually a day, and then the other day is just for a stress test if they need it, and imaging. So those two teams are absolutely separate, and we keep them separate because we do not talk about the donor to the recipient or recipient to the donor. If the donor happens to be related to the recipient, donor can tell the recipient what's going on, but we keep them completely separate because of the HIPAA.
I see. You just mentioned Dr. Starzl. Did you ever meet him?
Yes, I did.
Well, I did too. And it was an honor to meet him because
Absolutely.
he's a pioneer of liver transplantation,
Absolutely.
right?
Absolutely.
What a guy.
He's legend.
Yes. You know, and he was here in Pittsburgh for many, many, many years, and he trained a lot of people. So
Right.
I think this is probably why Pittsburgh is such a great place for transplantation in general, but also more specifically liver transplantation.
Sure.
Yeah.
Absolutely.
Yeah. What are the costs to the donor?
The donor surgery and their inpatient admission and their post-operative complications are covered by the recipient insurance completely. The job is protected for the donor, not the wages under the FMLA Act, because the legislation was passed recently where the FMLA Act protects them not to lose their job. But under the Donor Act, under the living donation, the recipient can choose to pay for their loss of wages or their lodging and their trip if they are in a different state. Not by cash, but you can pick up their tabs or pay for their lodging, and not by, you can't give them a cash or anything, but you can help them out if the recipient can help them out by paying for their hotel or their transportation. But we do have a program, Southwest Airlines, where the donor and the recipients can use that. We have free tickets for them to travel if they are donors.
So Southwest participates.
Yes.
Nice.
For both recipients and donors to help them out.
I see. That's wonderful. Now, a living donor probably thinks, what kind of surgery am I facing? Is there going to be much pain? Can you speak to that?
Sure. And as you mentioned, the living donor comes on a day for evaluation, meets with the entire team, which includes the hepatologist, the surgeon, the living donor advocate, and the behavioral, psych, social, and all our living donor coordinator and physiotherapist, the nutritionist, the physical team, the whole entire team. And we do talk to them extensively about the complications, the risks, and also the post-operative time off and all of that. And during that time, we explain to them that pain is one of the complication. And some people say that the pain is a threshold. Different people perceive pain in a different way. And some people say the pain is like very bad abdominal workout. Some people say the pain was better than their C-section. Some people say the pain wasn't as bad. Some people say pain was kind of hard for the first day. So different thresholds, but we do treat pain and take the pain seriously, and we do give them pain medications while they're in-house, and we do not send them home until they're pain-free and that they're able to take pain medications by mouth, and that they're able to tolerate pain medications by mouth, and not have any nausea. So we take pain seriously.
Now, you talked a little bit about risks to the donor. What has been, just from UPMC standpoint, what has been the track record for living donors and things that could go wrong?
Sure. So they have looked at, there's a big series called A to All series. They looked at all the donors in the multiple centers in the last 20 years of how the risks have been. And the mild complications have been around 20%, and severe complications have been around 10%. But our UPMC complications have been lower than the national average, but we can only quote the average in the country. So usual risks include anesthesia complications, which can have nausea or vomiting, or they may feel like they are little la-la land after a few hours after the anesthesia. Number two, sometimes being in the hospital puts them at a risk for infection. We make sure that they're in the private room. We do all the sterile techniques. And if they need a catheter, if they don't need a catheter, we take the catheter out and we minimize their risk. They get a dose of antibiotic. Number three, there is a risk of blood clot, because if they're in the hospital and not mobile, and any abdominal surgery puts them at a risk for a blood clot. Like me traveling to India for 21 hours, I have a blood clot risk too. So we put them on a blood thinner and like a compression device on the leg. And we also ask them to make sure that they don't lift heavy weight beyond 10 pounds for at least up to 10 weeks, because anything you lift, that can cause an incisional hernia. So we teach them those things, and we say, make sure you wear a binder, or we teach them that when you're lying down and when you're getting up from the lying down position, turn to the side and get up. We say those things, and intraoperatively there could be some bleeding or bile duct injury, and that's why I don't say anything to the patient which I don't say to the family, to my family. I always say go to a center which has the highest expertise, and to the surgeon who can handle if complications have to occur. And so Dr. Humor has 25 years of experience, and in our UPMC, thankfully, knock on wood, we have not had any donor major complications or any donor deaths, and we want to keep it that way. So so these are some of the complications which can happen, and we talk about these to the patients.
Yeah. So post-surgery, they go home. Is it also necessary to have some post-surgery medical follow-ups with the living donors?
Absolutely. So let's just say the donor had a surgery on Monday. They go home on Thursday. Majority of our patients go home between 4 to 7 days.
Wow.
And they come back if they go home on Thursday, they come back on Wednesday to see Dr. Humor. And usually at that time, he lets them come back in probably a month later, 3 months, 6 months, and a year. And he sees them at 2 years. So he follows them for at least 2 years. And during that time, he makes sure that they are, taken care of very well.
So the living donor, they sign up with UPMC through your website, and then they go through some of the evaluation. But I'm sure living donors have a lot of concerns. And you speak to them whenever they come in. And I'm sure that some just finally, after a while, just say, I just can't go through with this. So what happens to the recipient if that donor who matches everything just decides, I can't go through with this? What happens to the recipient?
So then usually in that case, what we say is that we give them a medical out. We don't necessarily tell the recipient this is the reason why the donor backed out. We just say, hey, if the recipient knew that there was a donor who came through for evaluation but backed out in the last minute, we'll say, hey, the donor is not approved for some medical reasons, and we wouldn't be able to divulge you why that is. So we give them a medical out, and we'll say, let's continue to find a donor for you. We'll work with you. We have living donor ambassadors. We'll work with you through the Living Donor Champion program. We'll continue to find a living donor for you until we get a cadaveric donor. But if there's no cadaveric donor in the near future, we continue to work with them to find other living donors for them.
How important is matching blood type?
The matching blood type is important, but many a times we have started doing ABO incompatible living donor liver transplant, and they just have to go through a couple of processes where they get some immunosuppression before prior, and they just have to have apheresis, meaning we check the titers on the recipient for, let's just say you are A and I'm B and I'm donating my liver to you. We check your B titers on you, and if it is lower enough, we actually remove some of the B antibody out of your body, and then give you rituximab, and we go have a ABO incompatible protocol, and you can still 3 or 4 weeks leading up to the living donor liver transplant, you should be able to still get the living donor liver transplant.
So you can cross blood types in some ways.
Yes.
Yeah.
And positive and negative doesn't match as much.
And the outcomes are similar from matching blood types to cross blood types?
Yes. We have done a couple, not quite a few, but we watch them extremely closely for rejection. There is a slightly higher risk for rejection for these people, but we watch them very closely.
I see. Can one prepare at all in any way for this surgery?
The recipient?
Or the living donor?
Yes. Donors, we usually say if they're smoking, we ask them to stop smoking. And if they are social drinkers, we say 2 weeks prior to surgery to stop drinking. And we ask them to, try to eat healthy and maintain the weight. And if they are on birth control pills, we ask them to stop the birth control pills if it's a female, obviously, and live a healthy life and exercise and do all the right things leading up to transplant. And obviously, if they're smoking, stop smoking.
I see. I was reading in 2005 in Baltimore, the Johns Hopkins Hospital. They started this kidney, I guess they call it a domino effect, meaning that they could share living donors. Now you may have your brother is a B and you're an O, whatever it is, but you guys feel it doesn't match. But there's some other people over here that need what your brother can do, and they have a relative on what you could use. I know kidneys are doing that. They're doing
Yes.
these shared, paired
Absolutely.
transplants. And I think that's been going on for a while. I think it started in the early 2000s at Hopkins. Where does living liver donors fall? Is this early in that process?
That's a great question. So we have been thinking about it, and I think we probably might have like a liver swap or a liver registry at some point in time, but it may take a little time for that, I think, only because I think we have more donors for each recipients coming up and signing up, and then we don't have that many ABO incompatible transplants as much. But I think we may be heading that direction soon. Maybe in a year or two, we may have probably all this time it wasn't possible because we didn't have that much of volume. But if we continue to have enough volume, we should be able to achieve that in a couple of years. Let's see. Let's hope to do that.
So do you think UPMC might be involved in something like that?
Yes, I think our hope is to try to be involved in something like that, because we would like to be innovative, pioneer, and help patients in any way we could. It's all about it all centers around the patients, right? At the end of the day, whatever we do, it should help patients. So
we have people watching this that are hearing what we're talking about, and they start to think, maybe I can help somebody and give them part of my liver and help save their life. And even when they sign up on their driver's license, whether they want to be an organ donor or not, what would you say to these folks?
I would say, please be a donor and save lives, because there are a lot of people on the liver transplant wait list, and we let these people pass away even though there is so much of unmet clinical need and untapped potential, and we let our own people succumb to the disease because we didn't tap into the right field. So please be a donor and save lives.
I think it makes a lot of sense, and from what I understand, people come from, in some ways, around the world. They come to Pittsburgh to get transplanted. Why do you think that's the case?
So I do think that, obviously, as you said, it's Dr. Starzl's legacy continues, and the expertise, the knowledge, and the team, and I think the reputation of the institution, all of that is a part of that. And we also accept global patients and international patients, and also that in some of the living donor liver transplant, we have pushed the envelope a little bit and have extended the criteria to patients with the cancer outside of the Milan, and to neuroendocrine tumor, and for some of the other diseases where other centers may not necessarily do living donor liver transplant. So those may be the reasons why the global patients are coming to UPMC.
And it seems like UPMC has really pushed, in some ways, some advertising to allow the public to know that you're doing not only just transplantation, cadaveric transplantation, but now really doing a lot of living donor transplantations.
Sure. So in my mind, I look at that campaign as not as an ad campaign, it is more as an educational campaign, saying, look, we do have this. In my mind, how I look at it is that if I am looking at it as a patient, right, or patient's family member, I'm looking at it and saying, oh, there is a living donor program in UPMC. They do offer this as an option. And if I have a family member who has a liver disease, I'm going to look at UPMC as an option to try to explore that to help my family. So more than an ad campaign, it's more of an educational campaign in my mind, to educate people that we do have this program and please utilize that. So that's how I look at it.
I understand. Now, as far as recipients and donors, a lot of donors are connected, even living donors are connected in some way, a friend of a friend of a friend, or a cousin or whatever, are connected in some way to a recipient. But I would imagine that there are people out there that just want to help, and they don't know anybody that needs a liver. So do you see that?
We see altruistic donors, yes.
So you call it altruistic donors?
Yes. And
Okay.
truly, I know it's a misnomer, because any donor who is donating is altruistic.
Right.
But we have this terminology called directed donors, non-directed donors, biological, non-biological, and altruistic. But in my mind, anyone who's donating is altruistic donor. But however, just for the purposes of for clarity, altruistic donors are the ones who come forward and say, I don't know anybody, take a piece of my liver and give it to anyone whom you think would benefit the most. And those we call them as altruistic donors. Though in my mind, in all our minds, anyone is an altruistic, anyone who's donating is altruistic donor.
Right.
But we just call it just to make it a little bit more simplified in our
Yes.
mind.
So you see those people, or you meet those people that don't know anybody to give it to. They just want to give the gift of life. You meet these people, right?
Oh, absolutely. Oh, I cannot. Okay, let's just say we all have good days, bad days, right?
Yeah.
So Tuesday, if I had a bad day, I come in on Wednesday and I see these altruistic donors and I say, you know what? My belief and trust and faith in the humankind is reinstated because I see 3 altruistic donors who do not know anyone. They are doing this because out of their kindness of heart, not for glory, not for anything. They're just doing it because they want to help someone and stop them from dying.
Yeah.
And I tell my son, sometimes he says, Mom, this is happening there, that's happening there, there's negativity here. I said, son, I understand that, but look at this. You come to me on a Wednesday clinic, and when you see these altruistic donors, you will know that there is God, there is faith, there is trust, there is people are nice, they're altruistic. Nobody wants other people suffer. No one wants other people to go through sadness. There may be some negativity, but majority of the people are kind-hearted. They want to help others. So Wednesday is my favorite day because that day I do see altruistic donors.
Interesting. So that lifts you.
That I live for Wednesdays.
Yeah?
Yes.
Yeah. So, you just said something real interesting to me. You're having a bad day. Well, when we look at doctors like yourself, we just think that doctors are kind of like there and they're going to take care of us. They're machines, they're robots. They can come in and save the day. But that's not how it is. You're a human being.
I am a human being with feelings.
With feelings.
And we also, and that's why, empathy is very important and compassion is important and emotional is different, but in tune with our emotional quotient. You have heard about that. So emotional intelligence is a very, very important. So, I'm not complacent or callous. When I talk to my patients and they're crying, I tear up. I'm not ashamed to say that because you know why? Because I'm a human being. I do not want my patients to suffer, and that is my empathy. That doesn't make me emotional. That makes me that I am empathetic. I am in tune with emotions with my patients. I'm connecting with them. I want to connect with my patients. This is not a job for me. This is my passion. This is my life. I want to make a difference in someone's life in some way. And I want my patients to live a happy life. They deserve to live just like I deserve to live. What mistake did they do? Nothing. So if there is, like my dad said always, sometimes physicians have this God complex. He said, physicians are not gods. You are helping them get to the right place. Everything else is taken care of by him. You're just helping them to get there. All you have to do is listen to them, be empathetic and compassionate, and just listen to them.
Well, you mentioned earlier in the interview that you kind of view your patients as part of your family.
Absolutely.
And I don't know if all doctors do that, but this doctor does. I
do.
That's wonderful. That's wonderful.
I do. That's the passion I have. Then why do you become a physician if you don't care about your patients as your own family?
Yeah. Well, that's terrific, Dr. Ganesh, and I think your patients are very fortunate to have someone like yourself that cares. Truly.
It's the patients who get me where I am because without them I wouldn't be here.
Yeah.
Because they are, it goes both ways.
Yeah, that's wonderful. That's wonderful. So if somebody wants to be a living liver donor who do they contact? How do they get involved with this? Who do they write or contact? How does it work?
So there is a livingdonor.org is the website, and they can reach that website, and that can go through multiple landing pages. And Susan has all the cards, and she will be able to provide to you guys about some of those cards, and she can give it to you
We
the
can
way
put
how you can
it
Susan
up on our
Piccarelli,
show, yeah.
and we can put it on at the end of we can put that as a slide.
Wonderful, wonderful. Well, I really enjoyed the time we had to spend together. It's just been an honor and a pleasure to talk more about you and all the wonderful work you do and the lives that you're saving. It's terrific.
It's a pleasure to meet you, and thanks for having me, and thanks for being strong, and it is my pleasure to be here.
Wonderful,
And
wonderful.
we can't do this without, we all have to remember, we can't do this without the donors and the patients. Without you guys, we wouldn't be here.
Yes.
So you have to remember that. It's you guys get us here.
Yeah, I hear
So-
you. So it's terrific. Well, thank you for coming, Dr. Nish.
Thank you so much. Thanks.
And I hope you enjoyed our discussion today on the power of organ donation and the gift of life that can give. And specifically now, the new trends in living donation. But I ask you this. If you, your mother, your brother, your sister, your uncle, if they need an organ transplant, would you accept it? Would you take it? I think most of us would say yes. So with that being the case, you go get your driver's license and they ask you, do you want to be an organ donor, yes or no? I think you have to ask that first question before you answer the second question. Would you accept it? And if so, I think it would be a great idea for you to be an organ donor. But now there's, with new technology, living donors. They've been doing kidneys for a long time, livers now. You can give part of your liver to somebody and it will regenerate within 3 months. I hope you consider that, because we have these wonderful professionals right here in the city of Pittsburgh that are doing terrific work and saving lives. So consider giving the gift of life. I hope you enjoyed our discussion. Thank you for watching. I'm your host, Lee Adams.